have another minute and then we'll get started. Okay, I think we'll get started. So thank you everybody for coming. My name is Miriam Lewis, and I'm very honored to be chairing this really, really exciting session with such fabulous presenters and faculty. This is a audience response system, so if you go to your phone, you'll be able to go to the CHEST app and click the polling, and you can follow along with us and answer the questions appropriately. I'd like to save the questions for last if possible. And we're also being live streamed, so I'm giving a shout out to those that are watching us remotely. So let's get started. Dr. Burjali will be talking about prescribing for sleep disorders in pregnancy and lactation.
Thank you, Miriam, for the kind introduction. I have no relevant conflicts to disclose. I want to start by showing you patterns of medication use in pregnancy. These are data that go from the 1976 to about 2008, and they show here is the mean number of medications used in pregnancy. This is any time in pregnancy, and this is in the first trimester of pregnancy. So you could see from 1976 to 2008, there was a significant rise in the mean number of medications that are used. And then when we look at the percent of women, so over here, the percent of women that are using 4+ medications during pregnancy, you could see that that number has significantly increased as well. So the myth that pregnant women don't use medications and we don't have to worry too much about it is actually not true. And then there's another myth that we have a placental barrier that is supposed to be protective, but the placenta isn't really much of a barrier when it comes to stopping medications from going into from traveling to the fetus. So most drugs cross the placenta. Heparins and insulin, which we all use outpatient or in the hospital, they are the notable exceptions. But the majority of the other drugs actually do cross the placenta. More efficient crossing would happen if the drug is lipophilic, if the drug has a low molecular weight, or if it's non-ionized at a physiologic pH. So this information is important when there are some newer drugs that have no human data. So if you look at how lipophilic the drug is or what the molecular weight is, then that could help you make a decision when there is no real data in there. So what's the state of drug research in pregnancy? Pregnant women are drug orphans. Unfortunately, there's a profound lack of data to guide clinical decisions. So there are a lot of challenges in drug studies in pregnancy. So there are studies that don't look at very many variables that might impact the interpretation of data. Studies need to be long-term. They are expensive. They lack funding. And then there's always the argument of do not harm, so you don't want to harm the baby. But there's a very nice paper that was published in 2018 in JAMA that talks about the lack of pregnant women in pregnancy. It's an opinion piece, and then it says that there's a common argument that it's unethical to include pregnant women in drug data, but actually it's unethical if you don't, because what happens is we end up where we are now. There's a lot of drugs that we know nothing about, and then we end up with disorders that will happen in pregnant women because they're just like the rest of us, I guess. So they have conditions, and we need to take care of them. And we can't just say, we're going to wait until you deliver, and we'll talk about why that's that's important later, because if it is connected to any adverse outcomes, then it's not safe to withhold medications. So pregnant women are excluded from trials in about 70% of the cases. 90% of all protocols that involve drug studies do not include pregnant women. So that is something that we have to think about. Next, I want to make sure everybody knows that the FDA classification has been retired, so A to X, and it's about time. I was asked yesterday how I felt about this happening, and I said, yeah, it took a while. Even though people feel like the FDA had been telling us what we should be doing, I think what's happening is we had a false sense of security with the FDA classifications, because there are a lot of category B drugs, for instance, that would not be safe to use in pregnancy because the data were not good. And there were a lot of category C and category D drugs that were okay to use because we knew about their pharmacodynamics and their ability to cross the placenta, or the fact that there were some human data about them. So this we no longer use. Instead, in 2015, the FDA has started the PLLR rule, which is the rule that is different. So going back to the problems with the letters, so they were a simple gradient of risk versus a discussion of what the risk is or the potential risk is. They didn't address the importance of the dose or the route or the gestational timing, and very importantly, they did not consider the indication. Because there are cases where the disease impact on the fetus that we're so concerned about may be worse than the impact of the drug. So if we're withholding medications, that could be very detrimental to the baby. So the intent of the PLLR is actually to give the clinician as much information as they could, and then update that information on a regular basis so that the clinician would have important information to go by, so that they can make that discussion. So the FDA is not telling them do this or do that. They, give them a guideline, and then the clinicians could do this. So how do we think about pregnant women with a sleep condition or anything else? I think it's important to first think about whether the condition is short-lived and self-limited. If it is short-lived and self-limited, then say no treatment, even if, when it's a cold and whatever. If the condition is not self-limited or short-lived, you want to ask if there are any adverse maternal or fetal effects or an impact on quality of life, which is important in sleep conditions. If the answer is no, then would consider no treatment. If the answer is yes to that, then think about, does the treatment harm the baby? If the answer is no, then you treat. If the answer is yes, think about whether there are similar medications that are older, because usually older medications have more data, and that may have the same efficacy and can treat the disease the same way. If that is the case, then I would treat with a safer medication. If that is not the case, then I would think about the risk of the untreated disease and whether that is higher than the risk of using the drug. If the risk of the untreated disease is higher, then I would definitely treat. If the risk of the untreated disease is lower than the risk of the drug, then depending on how miserable the mom is and how much she wants to be treated, but this is where counseling about what we know and what we don't know becomes really important. So other things to consider when prescribing for women in pregnancy, there are a lot of physiologic changes that might impact drug pharmacokinetics and drugs, and depending on whether the drugs are metabolized by the liver, by the kidneys, etc., there may be changes that you have to do. In many cases, we may have to give higher doses of medications in pregnant women because the metabolism is a lot higher. Other things to consider is that there's increases in coagulation, there's a decrease in serum albumin, so that might impact drug metabolism as well, increases in plasma volume and stroke volume. So think about all these things, and then the absorption and all of that, especially in the first trimester when you're prescribing in pregnancy. So prescribing during lactation kind of follows the same thought process. So you need to consider multiple things about the drug pharmacokinetics. So the drug oral bioavailability is important, so less is better. Shorter half-life is definitely better. Less lipid solubility is better. That means less crossing into the milk. And then more protein binding is also better. A higher molecular weight is protective, et cetera, et cetera. So you could see this. And then you also need to think about the infant's ability to metabolize drugs. So I have some drugs in here that may be relevant for the population that we're talking about. Think about barbiturates and benzodiazepines and fluoxetine, et cetera. So how common are sleep disorders in the pregnant population, and how often do we need to worry about this? These are data from the 1998 National Sleep Foundation poll in women, and these are data from pregnant women. And close to 80% of women had disrupted sleep, and about 15% or so had symptoms of RLS, and you could see that women take naps very frequently. So this is not an uncommon condition, and it's something that you may have to think of more commonly than not. So I'm going to give you, for the sake of time, and this is a bite-sized learning, we're going to talk about one disease, but we're going to think about the process of how to prescribe it and apply what we've learned so far in it. So restless legs is a common thing. I'm not going to talk about it in details. Janet is going to talk about that next. But I want to tell you that in the third trimester, about 20% of women have these symptoms. It usually gets better in the postpartum. So again, this is not an uncommon condition in pregnancy. So we have a 28-year-old woman who's at 20 weeks gestation. She's non-obese. She comes to see you with symptoms that are typical for RLS. Symptoms are significantly impacting her sleep, and she states that she's miserable, and she dreads evenings and nighttime. Her ferritin level is 70. She's taking prenatal vitamins religiously. So how would you counsel the patient? If you want to go to your polls, would you start her on oral iron or IV iron, as these options are safe in pregnancy? Would you advise the patient to reduce caffeine, smoking, and review her current medications with her? Would you counsel her that unfortunately all medications used to treat RLS are either unsafe or have no data in pregnancy, and just have her follow up postpartum? Counsel the patient that there are some drugs that may be justified for use in pregnancy. A or B are correct, B and C are correct, or B and D are correct. Okay, so 50, 38, and 10. 50, 30, 10, and 10. Okay. All right. So I'm going to go. I'm not going to give you the answer yet. We're going to go over therapy, and then I'm going to ask you the same question again. So therapy with oral iron is usually indicated if ferritin level is between 50 and 75. Vitamin C, the safety is debated, so I probably would avoid giving any extra vitamin C. Iron overload can be dangerous, so we wouldn't want to give iron to women who are not iron deficient. And then if ferritin level is less than 30, there have been some data from Moro Manconi that have shown that IV iron is safe, and it can raise ferritin levels and improve symptoms of RLS. Now, how about the data? So things that you're going to think about are something like that, rather than, okay, pramipexole is category C, so I shouldn't use it, et cetera, et cetera. So pramipexole has very limited human safety data. So we don't know too much about it. Ropinirole has no human data at all, but animal data do not show malformation. The one thing that I didn't mention before is sometimes teratogenicity is species specific. So something that is safe in animals may not necessarily be safe in humans. Levodopa, it has been used in pregnancy, but there are some very limited human data on it. But whatever we know doesn't really show any evidence of teratogenicity, but that doesn't establish safety, unfortunately. Opioids, the biggest concern is neonatal withdrawal, but there's no association with teratogenic symptoms. So if somebody is on opioids chronically, you want to, at the time of delivery, you want to make sure that the neonatologists know and they watch the baby for respiratory depression. Gabapentin has been used, and I think in Australia it's used relatively commonly for these kinds of women, but the true risk is really unknown, and we don't really know what that is. And you can see lactation, but I'm not going to go over that in a lot of details. Carbamazepine is known to be teratogenic, so it's really hard to justify using that for restless legs when we have other options. However, when you're treating, so say that you have somebody with seizures that are not responding to other therapy, but they would respond to carbamazepine, then it might make sense to use it, but not so much for restless legs. This is where the indication for the drug plays a big role. Clonazepam may be associated with neonatal withdrawal. Tramadol T1, so first trimester exposure in a Swedish registry, has shown some cardiovascular anomalies, but that has not been reproduced in other studies. Clonidine is a possibility. There's potential behavioral changes in the neonates, but clonidine is used for other indications as well, so that is definitely a possibility. Pregabalin, there's very limited human data, so it's really hard to know how that would work. Bromocriptine is used in women that have prolactinomas in order to induce pregnancy, and they can remain on it while they are pregnant. So this is a possibility. You need to weigh the risk versus benefit in that case. So again, depending on how symptomatic the woman is. Cabergoline, it's not believed to increase the risk of anomalies. It's used in fertility treatment, so it may be used, but may not be the best drug. Valproic acid is definitely teratogenic, so its use is not justified. So now I'm going to go back to that initial question, and I'm going to ask you to think about these options again, and then do the poll again. So IV iron, first option. Second one, reduce caffeine, smoking, and review current medications. And then counsel the patients that all medications are unsafe, or counsel them that there are some drugs that may be justified in pregnancy or combinations. So I'm going to let you see it while you poll, and then I'll move to the next one. Aha, I like it. So, well, you could have stopped there. So the right answer is B and D. So you would want to reduce caffeine. I mean, at any rate, women are not supposed to take a lot of caffeine because it can contract the uterus. Smoking is bad anyway. And you want to review other medications that may be linking to RLS. And then, let's see. B and C are correct. So B is definitely correct. Counsel patient, unfortunately. So there are medications that are safe, and we went over or relatively safe or justifiable. So opioids are a possibility. Carbamazepine we wouldn't want to use, but you could use clonidine as well. So there definitely are potential medications other than IV iron that could be used in the pregnant population. So, all right. So in summary, sleep disorders are prevalent in pregnancy, and their management might be challenging. Consider the risk of an untreated condition as well as the risk of the drugs. The risk of an untreated or poorly treated condition might be higher than the risk of the drug to be used. And animal safety data are not equivalent to human data. And in general, newer drugs have less safety data. And I thank you, and I just want to let you know, if you didn't know about this, there's a conference next week at the NIH about sleep and the health of women. It's free to the public. You can join remotely, you can watch it after the fact. But NIH is paying a lot of attention to the health of women, so should we. Thank you.
Thank you, Dr. Burgelli. If Dr. Shaib wants to come, circadian patterns in menopause, and again, we'll leave the questions to the end if possible.
Thank you for inviting me to be part of this very exciting session. I'm going to introduce you to the circadian patterns in menopause, or at least to what we know about that. I have no disclosures to make. We always, when we think about women, we think about flowers, and this is where the circadian idea and physiology came up when in 1792 the plant was noted to be sensitive to light and dark, with withdrawing its leaves and changing direction with light exposure. But definitely we know more about the circadian system now. We know it's more complex. We know it's modulated by dark and light. The exposure to one of them is going to trigger a whole system to interact, and that system through the SCN is going to modulate lots of things. Physiologic function, hormonal function, behavioral functions. Oops. So the SCN is modulated by light exposure or dark exposure, and it sends different signals to different parts of the body to modulate our behaviors, our physiology. It's a very complex thing, and the organization of the whole interaction is resulting in a complex behavior related to sleep and wake, feeding rhythm, and multiple other things. So we know that the circadian system is different among the different sexes. The SCN is different in morphology and electrical activity and gonadal steroid receptor. This is beyond the scope of this talk. But we know that the timing of the circadian rhythm in men compared to women too is different. Women have an earlier chronotype. We have an earlier phase in the circadian rhythm for the clock gene expression of the gene itself, in the frontal cortex, and melatonin secretion, body temperature, sleepiness, and sleep behavior. So coming into the topic of menopause, we come into the circadian system, and women are completely different. And then we think about menopause, we think about aging, and the two processes are going on together. It's really not known if a menopause is a result of aging of the circadian system, but we definitely know that menopause has lots of effects on promoting aging. So the aging process is affected by menopause. So as a basic question here, what do you think are the alterations in the circadian system that occur with increasing age? Absolutely. So all of the above are going to change, and I'm going to go over them one by one, just an introduction. And this applies to adult males and females, just before getting to the focus on menopause. So there is lots of changing that are happening related to activity, as in walking, physical activity, SCN firing, temperature. There is change in the amplitude of the circadian rhythm, and also there's a change in the phase. Some of the hormonal rhythms are occurring earlier on during the day. So this is for everybody, just the changes that are happening with advancing age. And it's interesting to know that it all starts and comes back to light exposure. So with advancing age, the eye changes are happening, the lens is yellowing, there's less light exposure, less sensitivity to the main Zeitgeber. There is an effect on the SCN, and then the rhythmic output from the SCN is reduced, so the amplitude is less, and whatever we talked about initially that's going to be modulated by this pacemaker is going to be blunted. And I just wanted to share with you an interesting fact that there are secondary Zeitgebers, like social activity for older people or being engaged people. We know people who retire or live in nursing homes have new Zeitgebers, like mealtime is the new clue to keep that system active and might boost it back. So we'll compensate to the lack of light signal. So we definitely know that with aging, there is a loss of the temporal coordination of the bodily system. There's an effect on the homeostatic drive too. There is disruption in the circadian system that is rapidly ongoing. So the system ages with the rest of the body systems. And definitely there are changes in the response of the system to entrainment. that occurs at the level of the retina, the SCN, and maybe there is more reduction in the expression of the clock gene. So talking about menopause, although I refuse to say that menopause is a sign of aging, but they are closely related, we see that coming back to the circadian system, those are the cardinal features of menopause, and you see that vasomotor symptoms are one of the cardinal features. It's one of the most bothersome features, and it has a circadian pattern, so there is something going on in there in the background. And definitely sleep disturbance is a common thing that we see in our clinics for women who are going through menopause. So when we talk circadian, we always talk about temperature. So we're going to move gears here a little bit and talk about temperature. And my first question is, what's the normal pattern of change in temperature at sleep onset? So this is a basic introduction. Excellent. So I like those answers. We all know that sleep onset is very closely related to the circadian rhythm of melatonin and body temperature. And whenever we talk about circadian and temperature, actually we're referring to a drop in body temperature, and we're always referring to the core body temperature. So with a sleep onset, normally core body temperature decreases. Actually, peripheral temperature increases because there's peripheral vasodilatation, and this is where heat loss from the system occurs. So coming to this is again talking about what happens at sleep onset, and this is core body temperature. Gradually through the 24-hour period, there's a decrease in temperature, and if you look at that, it's closely overlapping with the time where melatonin level is starting to go up. The temperature decreases, and it could be because of the heat production is reduced or the system is losing more heat. So usually peripheral temperature increases, and this is more related to reduced vasoconstrictor tone, more vasodilatation, and more loss to the environment. So which of the following is true regarding sleep in postmenopausal state? Great. Okay, I think we have the final answers. And we'll go over this together in detail over all those options. So the answer is that good sleepers have a lower core body temperature compared to poor sleepers. And I'll share with you this slide. This is a group of postmenopausal women. The upper one are women with higher core body temperature, and the lower curve is a woman with lower core body temperature. And definitely the group with the lower core body temperature have a higher sleep efficiency. So lower core body temperature promotes sleep onset and promotes good quality sleep. Talking about sleep and hormones in menopause, when menopause occurs, there is this shift on the hormonal milieu. So there's increase in LH and FSH and reduce in estradiol, as you can see here around that stage. And studies have shown that women who have a persistently elevated LH level, as in figure A, have a more disrupted sleep, more nocturnal awakening when compared to women who have a lower level. So the hormonal changes are also implicated in the reduced sleep efficiency, nocturnal awakening, and difficulty in sleep initiation. Again, always remember the difference for body temperature, difference between core body temperature and peripheral body temperature. Pre-menopausal women have a higher peripheral body temperature because there's vasodilatation and more release of heat to the environment. In post-menopause, the peripheral body temperature has lower amplitude and lower temperature values. Also, the study looks at menopause and the chronotype, talking about circadian and morning chronotype or evening chronotype. And it was observed that postmenopausal women have a phase advance of more than 1 hour. And this is also related to temperature and activity. So there is a phase advance that occurs during menopause. Also, again, looking at other markers of circadian activity that have variation during the 24-hour period. Post-menopause, women will have lower levels of cortisol, and the difference is more prominent in the evening and the afternoon hours. We cannot talk circadian without mentioning melatonin. We know that melatonin has an important role in regulation of the chronobiological activity and sleep, but also melatonin is thought of as an antioxidant, as an immunomodulatory, anti-cancer. It was also thought that it has a contraceptive effect in the past. And it is very interesting how the level of melatonin decreases through as we get older, and the lowest level are occurring at the same time that the other hormonal changes are occurring during menopause. So there is a lower level of melatonin when we get to the stage of menopause. So in women, usually circulating levels of melatonin are high when the endogenous estrogen level is low, and it has an effect on inhibiting reproduction and lots of other effects. In menopause, the levels have been shown to decrease. The duration of secretion and the level is decreased as we get close to the menopausal state. And definitely it has been tried on different problems that arise during menopause. I think we're going to hear more about vasomotor symptoms, but melatonin has been tried for osteoporosis. It has been shown to improve sleep quality in postmenopausal women. There has been lots of interest in cancer and melatonin, with the observation that there's a lower incidence of cancer, especially breast cancer, in blind patients. So there was maybe a protective effect from that. And there are also metabolic effects of melatonin. I think that's it for me. Thank you.
Thank you, Dr. Sheb, for that very comprehensive talk. And now Dr. Call is going to talk about insomnia and circadian disruption during pregnancy, so we're shifting a little bit.
Thank you very much for the invitation. Where is he? Oh, it doesn't. Oh, that's good. Okay. Thank you. I thought you were seeing the split one. So I'll try and go through this quickly. It's hard to do it in 10 minutes, but I'll give it my best shot. I have no disclosures, and according to the National Sleep Foundation, these are the hours that one should sleep. And for adults primarily, 7 to 9 hours of sleep is recommended. And you heard a lot about the circadian rhythm in pregnancy, so I won't go into much detail except that during pregnancy, there's increase in progesterone and estrogen, so to make sure there is implantation and gestation can happen, and these are regulated by the circadian rhythm. And there is increase in the prolactin, cortisol, and thyroid. So if there's any variation in the circadian rhythm, for example, if women are working the night shift and there's jet lag, this is going to affect the hormones. And as a result, people who work have shift work, they may have irregular menses, and they may have problems in infertility and even early fetal loss. So sleep is very important, and to maintain that relationship is good. And there are studies that have shown that there may be impaired fetal growth because of problems with the circadian rhythm and sleep deprivation in pregnancy. There are circadian rhythm has been associated, with changes in shift workers that there's a question whether preeclampsia is associated with circadian problems in pregnancy, but it has not been proven. What is of interest is that spontaneous labor occurs in the middle of the night, and rupture of the membranes occur at night, so much so that labor starts full on in the morning. So you could apply the principles whether induction of labor should be done in the morning or in the evening, and they found that if it was done in the morning, then the chances of from the labor induction to delivery was shorter, and less chances of requiring instrumental delivery for vaginal delivery. So although the Cochrane review didn't really show any difference, but one would tend to think that morning would be better. So we know that 78 to 79% of women have reported that their sleep is altered. And according to this National Foundation data in 2007, you can see that, so the lighter gray is when women say that they slept well for almost every night, and the darker one is that they slept well only a few nights in a week. And by the third trimester, 54% of the women did say that they did not have good sleep every night. So this is clearly a problem. And in this review by Mendel, where he looked at about 2,500 women in Philadelphia, the way they described their sleep disturbance was, poor sleep quality. They had daytime sleepiness, but one thing that was seen in most of the women was they had frequent nighttime awakening, especially in the third trimester, because we know that oxytocin causes contraction of the uterus at night, so that could explain that, or frequent urination, pressure from the uterus could all have contributed. Not only did they have physical distress from sleep deprivation, there was also psychological disturbances, because women lay awake thinking about whether the child would be normal, how their deliveries would be, and the insomnia sleep index on these patients was more than 50. Was more than 8 in 50% of the women. So about 50% of our pregnant women have insomnia. And just a quick definition is that, there's a difficulty with initiation and maintenance, even though there's adequate opportunity for people to sleep, and there are associated daytime consequences, not sleeping well, being anxious, etc. And the frequency occurs about 3 times a week. And chronic insomnia means that disorders can be for 3 months. Now, different tools that have been used to evaluate insomnia in women are Pittsburgh Sleep Quality Index, the Insomnia Sleep Severity Index. And so, okay, they don't sleep well. Are there any problems? Yes, there are consequences, not only for the mother, but also for the outcome. It has been known that if women don't get enough sleep, they have an increased level of IL-6, C-reactive protein, and therefore there's an increased inflammatory state. Gestational diabetes is more common if sleep is less than 4 hours, and any hour loss of sleep is associated with a 4% increase of getting gestational diabetes. More women develop repressive symptoms if they don't sleep enough. And women have a decreased ability to cope with labor. They feel more pain as opposed to others who have slept well. And they also have problems. There's a odds ratio of 1.5 if the woman has not slept enough the previous night. Low birth weight and preterm birth is also known if sleep deficiency occurs in physicians. In 1990, this New England Journal looked at the residents when they were pregnant compared to the spouses of their male residents and said, does it matter? These residents, of course, this is time before night floats occurred, when the women would be working 36 hours continuously. What they found is that these women would have premature labor, although they didn't deliver, but they had to be told to rest or had to be hospitalized. So it does have an impact. And also on depression. So in this study, they had about 1,200 people in women, and they looked at their sleep quality and suicidal ideation. I didn't realize that suicidal ideation is quite high in pregnant people and may lead to death. So they teased out the people who had poor sleep quality and did not have previous depression, and even then, after adjustment for all these, the odds ratio is 3.5 for suicidal ideation, and that's something really worrisome. So I wanted to throw a question here. 29-year-old woman is complaining of inability to fall asleep. She denies any history of depression or anxiety. She would like you to consider pharmacotherapy. Which of the following would you say to her? Most of the medications are teratogenic, and sleep disturbance is not important, so live with it. Offers cognitive behavioral therapy, or if it doesn't work, give her drugs, or choices A and C and C and D. Oh, fantastic. I think I could stop here. So choice C and D are correct. And there is ample data, strong recommendation that the primary treatment for insomnia, any kind of insomnia, including pregnancy, should be behavioral therapy, cognitive behavioral therapy for insomnia. And this has been recommended in clinical guidelines, be it for in psychiatry, be it for sleep medicine, and this article was from the Annals of Internal Medicine, so that's what. And if that doesn't work, then you should have a shared decision approach and talk about pharmacotherapy. So cognitive behavioral therapy has 3 aspects: cognitive therapy about sleep, behavioral interventions, and education. And it doesn't have to be one-on-one. There are different methods we can do as a group: telephone, web-based. Stimulus control quickly, so for the sake of time, always associate the bedroom with sleep. Do not do activities, which I think most of us are guilty about, and use the bedroom only for sleep and have a fixed wake-up time. Sleep restriction therapy, it creates, so if you're not able to sleep, leave and come back only when you are sleepy. That just helps consolidate sleep. And cognitive therapy, people have these ideas that if they don't sleep, they're not going to function, and they say, I have to try to sleep, which actually causes arousal. So to stay away from all of these. And of course, good sleep hygiene, keep a regular schedule. And this is based on, obviously, a lot of data which has shown that cognitive behavioral therapy improved. The latency to sleep was better. Total sleep time improved, and sleep efficiency improved. So there's a lot of data on regular insomnia, and the way you can deliver behavioral therapy, this was compared to whether a one-on-one person on internet delivered cognitive behavioral therapy. There was no change. So why not use it, extensively? And the VA has a nice system for CBT insomnia for their patients with PTSD and can be used for patients with insomnia and has worked well. And now we also have a study from about the pregnant women, and clearly by using CBT, it has helped sleep index, and the ICI has decreased by 8.4 points. Pharmacotherapy for insomnia. We know that, okay, some women are doing CBT and it's helping, but we are all afraid of the effects it can have on the mother, especially on the fetus. So we all dissuade ourselves from doing that. And more importantly, the patients are worried about taking it. But a lot of it is not true. So a lot of that may be myths. And in this study where they looked at births in UK in 1990 to 2010, this involved about 1,100 kids whose mothers had been on these medications. And as you see here, the odds ratio for congenital anomalies like cleft lip or cleft palate were very, very low. So this is a nice a table in this clinics. The authors are right here. And what basically I want to show is that zolpidem was associated with low birth weight, but did not have any congenital anomalies. And the infant dose was very low. So not to worry so much about this medication, and it could be used. Similarly, other medications are listed here, but diphenhydramine, believe it or not, is the most commonly used among pregnant women for sleep, and it has been shown not to cause any congenital anomalies. Not only does it help in the pregnancy period, we know that after delivery, a lot of women go into postpartum depression. And in this study, they had 44 women, and they divided them to get either trazodone, diphenhydramine, or nothing. And clearly, the sleep efficiency and the sleep time improved in women who were given either of these medications. Now, it's funny that after this, in this study, what they did is they gave all the information which was validated, and they gave it to about 160 women and said, if you had insomnia and you're pregnant, which one would you pick? And a big majority said they would still go with cognitive behavioral therapy, which means that people are really afraid to be on medications. So in summary, I'd like to say that good sleep is very important for a healthy pregnancy. Pregnant women are at increased risk of insomnia, and they will, this may be secondary to hormonal changes or the body changes, and we should pay more attention to it. We often ask about it in the 3rd trimester, but we really should be asking even, in the 2nd trimester and even at 12 weeks. And if they're having sleep problems, we should probably offer cognitive behavioral therapy and then give them some medications. Thank you for your attention.
Thank you, Dr. Call, for that wonderful overview. So still on pregnancy, we're going to now, once this loads, apologize, we're having some technical issues. Dr. Myers is going to talk to us about restless legs during pregnancy. I lost the mouse.
Well, while we're waiting, I'll just let you know, I have no disclosures. Did it go?
Sorry, I think I made a mistake. I see it up here. Here we go. I got it. All right, thanks for your patience.
So for the next 10 minutes, I'm going to go over restless legs in pregnancy, and I have no disclosures. So a quick overview of how the talk will go, starting with the definition. It's going to just talk briefly about restless legs. If you are familiar with the International Classification for Sleep Disorders, the 3rd version, you know that restless legs is just one of many different sleep-related movement disorders. You might also hear it called Willis-Ekbom disorder, or WED, and that's actually the more the newer term, and it falls into both idiopathic and secondary forms, and we commonly think of pregnancy as being one of those secondary forms. So brings me to the first question, just jump right in. So you are the sleep specialist or the pulmonary doc doing sleep medicine, and you're asked by your OB colleague about a 35-year-old prima gravida female at 30 weeks, so coming into her third trimester, complaining of an inability to fall asleep because her legs hurt all day long. But she feels better when she moves them. She's taking iron, folate supplements, and says the pain keeps her up, and she wants medicines. Please help. So you advise which of the following? Should I advance someone? Oh, okay. Okay. In the interest of time, I'm going to cut you short. So, yes, most of you picked the correct answer, and that's that the symptoms may not be due to RLS in this patient, although it sounded pretty convincing. It's important to think about the definition of RLS. According to the International Restless Legs Syndrome Study Group, it involves 4 main criteria, and that's the first is really that you have an urge to move the legs that occurs primarily with rest or inactivity, and that it's relieved with movement or partially relieved with movement, and it has a circadian pattern so that it's primarily in the evening or at nighttime. And that's different from the International Classification of Sleep Disorders with the AASM, because that also includes an association with distress or with a sleep disturbance or some kind of impairment to establish the diagnosis. So the IRLS-SG study group uses this rating scale, and if you look through the literature, you hear this talked about several times. But this rating scale is kind of cumbersome. It was really intended to improve clinical research and practice. But what you might use in your clinics is this brief scale, the brief restless leg scale, talking about all those 4 items. But really, the key part of this is trying to get at how severe is the patient's disease. Is it just once a month, mild, or is it as often as 4 times or more, or even daily per week, which is the most severe? So looking at the prevalence of this disorder in pregnancy, a recent systematic review and meta-analysis looking at over 50,000 patients found that there's an increase in the prevalence with each subsequent trimester. So the greatest prevalence is in the 3rd trimester, and then it drops off dramatically after delivery. But overall, it's about 2 to 3 times more during pregnancy than in the non-pregnant state. It's important in this study, if you see it, that it was only English-speaking literature. It completely did not include Africa as well as Southeast Asia, because they just didn't have enough data. So some of the predictors, and this is important, as you're thinking about both your pregnant and your non-pregnant patient, if they have a past history of RLS, if they have a family history of pregnancy with RLS, and a low hemoglobin, those are all predictors with increased odd ratio for development. But one very important one is that if the patient themselves had a pregnancy and had RLS in the past, that's a very high risk of developing it again with subsequent pregnancies. So if you have a woman like that, you should consider checking their iron ahead of time before they even get pregnant, if they're thinking about it, and maybe even do the treatment up front, for example. And then another study, this is more recent, another recent study from Michigan, I think, of about 1,500 patients, all self-reported symptoms. They found as many as 36%. So you saw in some of the other talks, it was anywhere between 15, 24. This is as many as 36, and this is in a US population. About half those women had moderate to severe symptoms, and they were twice as likely to report poor sleep and poor daytime function. And then, as you can see with time, those symptoms escalate with pregnancy as it progresses. In this slide, it just looks at the distribution, not only with race, but the frequency, you can see that many patients are having moderate to severe symptoms, looking at 30 to 40, up to 50% having 2 to 3 times per week or more. So what are some of the complications associated with gestational restless legs? You can go to these studies and look at them, but just be aware, pregnancy-induced hypertension, gestational diabetes, those are both associated. This group is out of West Virginia, those 500 patients, for those 2 different studies, an increased risk. And the more RLS you had, the higher your risk. In addition, that other study I mentioned about the patients from Michigan, there's a dose-response relationship between the frequency of the RLS symptoms and the severity of their sleep disturbances. And then we worry about the effect on the fetus, effect on delivery. It's not really so clear. This area has so much research that has yet to be done, really. So we're not really clear about associations with threatened abortion, premature labor, difficult deliveries, C-sections even, or intrauterine growth retardation. So you can't give a talk about RLS WED without discussing the pathophysiology. In all comers, pregnant or not, it's been shown that there is an association with iron metabolism and with the dopamine and dopamine receptors. There may actually be a brain iron deficiency, but then it's more than that. There are genetic factors, and specific to pregnancy and even non-pregnant, there are many variants, genetic variants that are associated with iron physiology, and these are predominantly within neural structures, such as in the spinal cord. There's even an association more recently with glutamate as well. But what about pregnant women? Well, pregnant women have been shown that when they have RLS, in this study, they looked at patients who had RLS and they were found to have lower levels. My arrow's not working here, but they were found to have lower levels of hemoglobin and mean concentrations of hemoglobin. And then what you see here on the right side there is that there's a unidirectional flow of iron, basically coming from the mom and only going to the fetus, so that iron goes where it's needed during development. But that leaves the mother at potential risk for iron deficiency. What are the factors about pregnancy that lead women to develop RLS? Well, it may just be that some women are more likely to develop it, and that pregnancy unmasks RLS in susceptible women. In addition to iron, there's folate metabolism, questions about vitamin D status, and then changes in hormones over the course of the pregnancy. But women will also develop increased weight, water retention, venous insufficiency in the legs, and there may be altered hemodynamics and peripheral hypoxia that subsequently result in the development of RLS. So I only put this up here. Carolyn D'Ambrosio let me use this slide, but the reason I included this, it looks a little complicated, but it's really, you want to make sure you're accounting for all the things that aren't going to require medicines. So looking at all the mimics, looking at all the aggravating factors, and then just in the bottom right-hand corner, that's where you're talking about checking for vitamin, iron deficiency, and then treating when need be. So what are some of the mimics? I direct you to this study. It's the International Restless Legs Study Group by Pichetti and al. It's a very nice review. If you are interested in the topic, read this paper. It'll talk about the mimics and the less common ones, and the importance of being able to associate whether or not it is associated with circadian rhythm and whether movement makes it worse or makes it better. It helps you find out what they might actually be suffering from if it's not from RLS. So here, next question. So which of the following can alleviate RLS in pregnancy? Okay, I know you all can read, so have at it. Yes, yes. It's the end of the day. I like to make it a little easier. Okay, so yes, all of the above. All of those have been associated with pregnancy, and it's thought that if you do some of these things, you can improve their symptoms. This, in the article I mentioned by Pichetti et al., one nice thing that it does, in addition to talking about the diagnosis and non-pharmacologic therapies, is it very nicely outlines iron assessment as well as the different medications that you can use in refractory RLS and WED. I want to highlight, though, that of the exacerbating factors that we've talked about, OSA is one of the factors that we know in non-pregnant women and in men too that can be associated with RLS. So perhaps this is one area that I think has more room for us to manage, and there is therapy for that is non-pharmacologic. Okay, so other non-pharmacologic therapies. There's massage, of course, sleep hygiene, avoiding alcohol, tobacco, and then yoga, moderate exercise. Okay, next question. Which of the following treatments are pharmacologic options in pregnancy and or lactation? So, I'm not sure if it's showing up. Oh. So, okay. Everybody's right if you chose them. It's really all of them, all of the above. So the article that I mentioned does go through many of these, but I want to highlight just a few about and talk about the dosing in pregnancy. There's, as we saw in the prior lecture, there's limited safety data, but just note that if you're familiar with using these drugs and other disorders, these are pretty low doses. So it's very low doses, usually in the second or third trimester or beyond. None of these are really recommended in the first trimester, except for iron when you do see iron deficiency. Just note that if someone is on carbidopa levodopa, that it may inhibit lactation post-pregnancy, and then also if patients are on opioids, you need to let the caregivers know for the fetus or for the baby after birth. So just a quick note, almost finished. Restless legs and depression. Restless legs is correlated with depression. So if you're going to treat the depression, SSRIs are known to increase RLS symptoms. But if you're going to pick a drug, bupropion does not appear to aggravate RLS WED. And so you can consider that after the first trimester and with lactation. So, okay, in summary, identify iron deficiency early and treat, and know that RLS symptoms peak in the third trimester, but may resolve with delivery, but can also persist. Beware of the mimics and consider non-pharmacologic approaches first. Medication should be the lowest dose, shortest duration, and reassess frequently. And then, of course, always review the risks and the benefits of medications with your patient during pregnancy. Thank you.
So Dr. Myers has to rush just to get plane to catch. So thank you, Dr. Myers. I'll be very quick. I know we're a little bit over, so I will make my talk very, very quick. I hope I get this right again. Okay. So we're going back to vasomotor symptoms. We're going to leave pregnancy, and now we're going to go back to vasomotor symptoms. I do not have any disclosures. So of the typical menopausal symptoms women have, by far the most prevalent are vasomotor symptoms, also known as hot flashes or night sweats, with a prevalence anywhere between 36 to 87%. So I think it behooves us to understand a little bit more about vasomotor symptoms. In addition to that, a lot of women who have vasomotor symptoms will also experience some sleep disturbances that are associated with the hot flashes, and I'll touch upon that briefly in this portion of the talk. So what are the risk factors for vasomotor symptoms? So if you're a woman who's obese, smoke, you don't exercise much, and you have a lower socioeconomic profile, you're much more likely to get hot flashes. In addition, if you're African American, you're much more likely to have more severe, more frequent, any longer duration of hot flashes compared to, for example, an Asian woman whose risk is much, much less. And so for years, we didn't really understand why that was, but it looks like there might be some clues coming in the pipeline with some genetic testing. So last year, Cardinal et al. Published in the journal Menopause a very interesting article, which showed that women who have variations in the gene that codes for the tachykinin receptor 3 are much more likely to have hot flashes compared to women who don't. And I want you to keep this tachykinin in mind, because you're going to see it becomes relevant for not only for the pathophysiology of hot flashes, but also potentially for future treatment options. So the pathophysiology is still poorly understood. But what do we know? We know that it's not the absolute level of estrogen, but rather the rate of estrogen withdrawal that initiates or triggers the onset of hot flashes in the early menopausal period. And we know this really by two lines of evidence. The first is young girls who have low endogenous estrogen don't get hot flashes. And we also know that women who've had a surgical menopause, where there's a very abrupt and dramatic fall in estrogen levels, experience much more severe and frequent hot flashes compared to women who've had what's called a natural menopause. Now, while estrogen withdrawal describes the initiation or the trigger of hot flashes, it doesn't in any way describe the thermoregulatory response. And Dr. Shaib alluded to this a little bit earlier, but most of us, all of us actually, have a thermoneutral zone, above which if the core body temperature rises, we start having sweating, and below which we shiver. And that zone is approximately 0.4 degrees Celsius. Okay. So I have you look over here in symptomatic menopausal women. If you see here, their sweating threshold is decreased and their shivering threshold is increased. And that results in a very, very narrow thermoneutral zone. So it doesn't take much variation in their core body temperature to trigger the sweating or the shivering. Now, having said that, the thermoregulatory response is actually, we believe, centrally mediated. So not very well described, not very well understood, but it appears that when there's low estrogen, which occurs in menopause, there's a rise, as we all know, in LH and FSH. That alters the pulsatile activity of the gonadotropin-releasing hormone neurons, which in turn affect the KNDY neurons, right, back to that tachykinin that we spoke about in the previous slide. And it is believed that it is this which is responsible for the thermoregulatory response seen in hot flashes. So other possible pathways include perhaps norepinephrine and serotonin. Again, not well mapped, not well understood, but hopefully we'll have some more answers soon. So question number one, we're going to move on to the effects of hot flashes on sleep. The most common sleep complaint in menopause is A, frequent awakenings, difficulties falling back to sleep, difficulties initiating sleep, or early awakenings. All right, so most of you got this correct. This is absolutely true. So the answer is frequent awakenings. So data from the SWAN on the Australian longitudinal study showed that frequent awakenings is by far the most common complaint women with menopause or hot flashes have. And if you look here, it's actually quite interesting, whether it's frequent awakenings in the solid circle, waking up early, which I think was this number 2 choice, or versus trouble falling asleep, all of these sleep complaints progress across the menopause. And why that is not clear. What is clear is that most, but not all, nocturnal hot flashes are associated with an awakening. But interestingly, it is the duration of the hot flash, right, rather than the number, that correlates with sleep fragmentation and delayed REM onset. Okay? We also know that the majority of hot flashes cluster in the first half of the night. And that makes sense because we all know that REM is a thermoregulatory suppressive state, and therefore it's unlikely we can mount that thermoregulatory response. Right, question number 2. I'm moving a little bit quickly, I apologize in the interest of time. So how do you treat, all right? So which of these non-pharmacotherapeutic treatments for VMS is supported by strong scientific evidence? Acupuncture, yoga, exercise, hypnosis. Okay, so the answer might surprise you. It's actually hypnosis, okay? And I'll show you why. So this is a level of evidence table that was published in 2015 as part of the position statement of the North American Menopause Society. And I'll have you look here at exercise, yoga, and acupuncture. Okay? They do not recommend level 1. So that means there's very strong evidence to support its inefficacy. Okay? On the other hand, cognitive behavioral therapy and hypnosis are level 1 recommend. Okay? So again, it's a busy slide. We don't have time to go through it. The slide will be available in a few weeks online when this session becomes available, so you can look at it then. So question number 3. A 56-year-old female with a history of coronary heart disease presents with predominantly nocturnal VMS that are very disruptive. Which of these would you recommend? A, hormone replacement therapy, B, gabapentin, C, paroxetine, E, vitamin E. And we're wrapping up, so we'll be done in a couple of minutes. Okay, so the answer might surprise you again. It's actually gabapentin. Okay, and let's look at why. It'll take us about 3 slides. So if a woman has mild hot flashes, you do not need to treat, and you could try the behavioral methods we described. On the other hand, women who have moderate to severe hot flashes, hormonal therapy is the most effective, so you're right in that regard. However, there's contraindications. So if a woman has breast cancer, coronary heart disease, like our patient did, or previous thromboembolic disease, those are absolute contraindications, and you should not use them. On the other hand, if a woman has a contraindication or does not want hormone replacement therapy, the SSRIs or the SNRIs have been FDA approved. Typically speaking, paroxetine is much lower doses, and the results are much more rapid in terms of controlling for hot flashes compared for depression. So within a week or 2, you will notice an improvement in the symptoms. If you want to use other off-label antidepressants, such as venlafaxine, those are just as effective. Now, our patient benefited from the anti-epileptics, such as gabapentin or pregabalin, because it is best for patients who have disruptive nocturnal hot flashes, and that was her main complaint, right? Because it alters the arousal threshold, sedating, and therefore she can get better sleep. I'm not going to go through this. You can look at this later. It's a treatment algorithm as to decide what would be best. I'm going to end with the last 2 slides, which is something that's coming in the pipeline. I mentioned earlier the neurokinins. Well, last year in The Lancet, there was a randomized trial looking at a neurokinin 3 antagonist versus placebo, and it was administered for 4 weeks in women who had moderate to severe hot flashes with a 2-week washout period. What they found was surprising and promising. They found that the average total weekly number of hot flashes decreased by 85% at baseline for those taking the antagonist compared to placebo. And the estimated percentage decrease was 45%. So promising drugs in the pipeline. Hopefully when we talk about this the next time, we'll have some more data, all right? And I'll leave you with the slides which has some further resources. So I thank you for your attention, and I apologize to the next group that we're running a little bit over. Are there any questions? We can maybe take them on the side if somebody has questions.
Are you all here for the plural session? Otherwise, we can talk about hormone replacement therapy. It's up to you. Are we ready to start? Not quite, right? Is pink? So we really want this session to be fairly interactive. We have a number of cases